Hello, everyone. Thank you for joining us for Creative Healing for Youth in Pain, or CHIP's November webinar, Stomach Aches, Brain, Gut, Autonomic Nervous System, and Pain. My name is Ashley Matejka, and I am the Executive Director of CHIP. For those of you who are new to CHIP, CHIP is a one-of-a-kind nonprofit organization that is dedicated to empowering youth to heal by altering the brain's pain circuits through educational resources, peer connection, and exposure to creative healing experiences. Today, we are thrilled to have Dr. Beate Beinvogl as our guest speaker. Dr. Beinvogl is the Assistant Professor of Pediatrics at Harvard Medical School. She completed her pediatric residency and pediatric gastroenterology, hepatology, and nutrition fellowship at Boston Children's Hospital. She's an expert in pediatric disorders of gut-brain interaction, also known as DGBI, and the autonomic nervous system. She's a multidisciplinary abdominal pain program member at Boston Children's Hospital. Research focuses on irritable bowel syndrome and multidisciplinary care of patients with DGBI. We're also joined by CHIP's webinar moderator, Dana Pacholski. Dana is a member of CHIP's board of directors, as well as the board of the UCLA Resnick Neuropsychiatric Hospital, and is vice chair of Cedars-Sinai Board of Governors. She's also vice chair of the USC Parent Leadership Circle. Thank you, Dr. Beinvogl and Dana, for joining us today. Before I pass it over to Dana, I would like to go over a few housekeeping items. First, please be sure to enter your questions in the chat throughout the webinar. Dana will try to incorporate audience questions throughout today's conversation. Second, I also want to note that our webinar is being recorded. A replay of this webinar, along with all previous CHIP webinars, are available on CHIP's YouTube channel. I'll be putting the link in the chat, and also an email will be sent to all those who registered today once this webinar is posted on CHIP's YouTube channel. Finally, I would like to ask you to consider making a donation of $25 to CHIP if you find the monthly webinars valuable. Donations can be made at mychip.org/donation, and I'll be placing that link in the chat as well. Now we're ready to get started.
Thank you, Ashley. Welcome, Dr. Beinvogl. Thank you, everybody, for joining us this morning. It's very exciting to have Dr. Beinvogl with us because her experience is something that I think is so relevant, especially right now, and covers really the entire body and its communication channel. So, Dr. Beinvogl, thank you so much for giving us your time this morning. I'd love to talk about just starting off with, there's so many people I know on this webinar today, and so many people I know in general that will be watching this later that say, I've had stomach aches for a really long time. I've been to several doctors and, they ruled out everything, but I'm still suffering. And now I might have some more anxiety, or I'm more nervous about it, or I'm worried about eating. And, talking about how does the body work and how does the mind interact with feelings like that? And then how do the systems start to have a glitch in the system effectively? I know we talk about software and hardware, so I'm really excited for you to walk us through the process that our body goes through and how we can help ourselves.
Yeah. First of all, thank you so much for having me today. I'm excited to be sharing, hopefully a lot of information about these kinds of disorders with you to help the understanding. So yeah, this is what we commonly see, right? Patients that come to us with a long-standing history of abdominal pain, sometimes other symptoms like diarrhea, constipation, nausea. So when I talk about GI symptoms, I'm going to be referring to all of those, but of course, with the focus on pain. And it's frustrating, right? We've been to so many doctors. Everybody says everything's wrong with me. All the testing has been normal. The doctors say there's nothing wrong with you. It's all in your head. Those are the kinds of things that we hear. And the fact is that patients are experiencing real pain, real nausea, and real symptoms. And I think to jump right in, right, the best way to understand this is that our body, right, consists of hardware. So just like a computer has hardware, the body that we can feel, that we can touch, that we can do great exams on, and that's where our medical diagnostics are very good, doing endoscopies and labs and stool studies, and lots of diseases can be very easily diagnosed that way, but we also have a whole software that operates in our system. And that software in the gastrointestinal tract is the movement, right? The nerves that are responsible for movement, and also the sensors that sense fullness, being hungry, having to go to the bathroom, things like that. And when we talk about things that can go wrong, right? Yes, things can go wrong in the hardware. That's actually relatively easy to sort of figure out, but you can also have a software glitch. And that means, right, there's a problem within the sensors or with the movements, too fast, too slow, the wrong way. And those software glitches, right, that's sort of the focus of what we're going to be talking about today, because the symptoms that those present with in patients are pain, abdominal pain, nausea, sometimes vomiting, constipation, diarrhea, or any combination of those symptoms. And these are the kinds of disorders that actually have a name, these software glitches, and these are the disorders of gut-brain interaction, and that's going to be the main focus, of course, of what we're talking about today.
So really the communication network within our bodies is what we're talking about, right? For the lay person, how does our body talk to itself? When we eat some food and we think, okay, it's just naturally going to digest this food. And yet our brain is saying, oh no, we're too busy right now. We're not able to digest that food. And then how does the stomach react? What does it know what to do? And what's the effect then on the body?
Exactly. And I think that's maybe to jump right into what actually normally happens in our body. And when I talk about these kinds of disorders, these software glitches now being called disorders of gut-brain interaction, I think it's really important to understand, like, what actually is this gut-brain interaction and what is this gut-brain axis. And a lot of research has been done over the past decades to really help us understand, and has really fundamentally transformed our understanding of these kinds of chronic GI pain disorders. And so just to sort of think about the gut-brain axis, and we'll start, I'm a gastroenterologist, so I'm going to start with the gut, right? So I think everybody has heard of the second brain, right? Our gut being like a second brain. So our gut has millions of nerves that help regulate digestive function. And that's mostly movement of the GI tract, it's secretions, and a lot of that actually operates in and of itself, right? We don't never have to think about it, thank God. And so secretion, movement, right? And a lot of it operates with reflexes. And then we have other parts of our nervous system, the so-called autonomic nervous system, right? Sympathetic, parasympathetic, you may have heard of before. And those are very important at modulating. So it also affects how the enteric nervous system functions. And this autonomic nervous system, right, originates in the brain, in our brain, and then sort of moves through different channel. And specifically the vagal nerve is one nerve that's very important in this context, and that helps also modulate the enteric nervous system, the movement of the GI tract, secretions of the GI tract, and also blood flow to the GI tract, and also other functions within the GI, within our bodies. And then, of course, we have our central nervous system, which is the brain, sort of the operator of this whole system, this whole software system. You kind of think of it as an operating system. And the brain is responsible for actually perceiving what happens on the inside and reacting to it. So if there is pain, right, then, oh, do I have to go to the doctor? Do I have to lay in bed? Do I have to go to the ER? Or is this nothing? Am I just full because I had a big breakfast? So that kind of reaction. And then, of course, it's way more complex than just these three components, because there are other factors that also play a role, like your environment, like what you see, how other people react to these kinds of signals. We know that hormones, the immune function plays a role. So cortisol, for example, is one of the hormones that plays a huge role. And so this is sort of what the microbiome, right? The bacteria that live in everyone's gut play an extremely important role. So this is sort of this complex system that we now know as the gut-brain axis, involves all these different parts. And you can imagine that if you actually have a disruption at any of these levels, right, whether the sensors in the gut are oversensitive, or the transmission to the brain is sort of faulty by the brain over perceiving certain signals, that's when you start running into problems. And that's when you start potentially experiencing pain, even though, quote unquote, there's nothing actually wrong, yet there's no disease, but there is something wrong, which is that the nerves are actually misfiring, right? And this is sort of the concept of primary pain disorders. The pain itself is the problem. The pain itself is the disease.
And that's the new term of functional neurology, right? Where we're seeing where there's not an actual diagnosis in the physical hardware, but we know that the pain is actually occurring. It's not just in our heads. It is very real.
Exactly.
And with that, I kind of wanted to go back to touching upon the autonomic nervous system, because I feel like it's something that we can't talk enough about as far as the teeter-totter of the parasympathetic and sympathetic nervous system. And I really like to talk about how the body naturally is teetering and tottering between the two systems until one day it gets stuck in the fight or flight, and how the brain stops it starts reallocating systems to hold steady. So for example, if we're going into fight or flight, slow down motility, send chemicals from the brain to the body to keep us awake, reminding us we've got to be ready because we need to go to quote unquote battle, right? We're in fight or flight. So if you could talk a little bit about that, I think it's a really good point right here.
Yeah. So exactly, right? If this fight or flight response, of course, it's sort of back when, you can sort of, or you can imagine if you're out in the wilderness, right? If you have that kind of fight or flight response, like if you're about to run away from something dangerous, right, then it's not a good time to use the bathroom, right? It's not a good time for all sorts of normal bodily functions. And so that's how your body sort of shuts certain things down or allows certain things to happen. And these days, we may not be running away from a big animal or a threat like that, but we may have anxiety about something else. And that anxiety creates a similar response in our body. And that's where, anxiety can correlate or can cause some of these symptoms. But on the other hand, these kinds of symptoms can also result in anxiety, which can then worsen the symptoms, right? And this is a vicious cycle that we often see that, patients come to us saying, oh, I was told this is all anxiety. Well, chances are it probably isn't all anxiety. And I like to say anxiety doesn't help the symptoms. And a lot of patients actually develop anxiety as a result of the symptoms. But sometimes anxiety can also trigger symptoms, right? We all know when you get really anxious about something, you might, your cheeks turn red, you might feel a little nauseous or the butterflies in your stomach, or you might have to go to the bathroom. Like that can happen, but often it's not that easy. And it's a lot more of the chicken and the egg, and that the symptoms cause anxiety. And, if you just think about an example, somebody who has pain and may have diarrhea or urgency to use the bathroom, right? Sort of classic symptoms of irritable bowel syndrome. If you're in school and you have to excuse yourself from class 2 or 3 times, that might make, teenagers, which are the most commonly affected by these conditions, very uncomfortable. And they may not want to go to school. And within days, they have developed anxiety, right, around their symptoms. And I think it's very important to differentiate sort of or acknowledge the fact that anxiety can trigger symptoms and symptoms trigger anxiety, because that's such an important and also in a way detrimental vicious cycle that we kind of have to get at to make sure that we can disrupt that so that it doesn't keep getting worse. It doesn't keep getting worse.
I mean, that's so important, the comorbidity between the psychological effect and the body looking for what's coming next, and then the stomach and this interaction. It just starts this cycle. And then we've seen this, that the brain then latches on to this pain cycle. And what happens next? Once the body has found this glitch, this dysregulation in the communication system, what happens in the brain? And what do we do? What can we do about that?
Yeah. So I'll just take a little bit of a step back to kind of give the bigger picture. So when we talk about these software glitches, right, which I'm going to be referring to as the DGBI, so disorders of gut-brain interaction, they used to be called functional gastrointestinal disorders. Then before that, it was chronic abdominal pain disorders. They sort of evolved over time. And this most recent renaming of these conditions really is because of the research that we have, or what we've learned, right, over the past few years or decades, that really have changed the way we see these disorders. And the sort of key concepts of what happens in DGBIs is that one on the is sort of on the level of the gut. If you think about the gut-brain axis, and one's on the level of the brain, and so I'll get to sort of that question in just a moment. But starting again on the level of the gut, right? We talked about that the sensors are off. So patients with DGBI, they may experience what other people might feel comfortable eating, a bagel or half a bagel, and a patient that has a type of DGBI might feel excessively full or nauseous. Even though, again, if you were to test everything might come back normal, right? The stomach emptying is normal. There's no inflammation. There's no celiac disease, nothing. They just feel full, nauseous, uncomfortable, have to run to the bathroom after they eat. Those kinds of symptoms, for example. And that's because the sensors are off, right? A little bit of a stretch gives a signal to the brain, oh my gosh, I'm so full, I'm feeling super uncomfortable, right? It's almost like a false alarm, right? I like to share with patients this analogy of being in a parking lot and just touching a car and the alarm goes off, right? Or even you just hear an alarm go off and you look around and nobody broke into a car, somebody probably just touched it and it just went off, right? And it's loud and it's disruptive and it doesn't stop. And you just try to distract yourself. You try to look away, but you just can't because it's loud, right? And you worry. Is there a car? Did somebody break in? And so that's a similar idea that these sensors are misfiring very, very loud, right? And then, of course, we have, and so this concept of being overly sensitive, right, to distension of the stomach, distension of the bowel, bloating, right, all those symptoms that we then experience, that is a concept that in the medical terminology we call visceral hypersensitivity, right? So the viscera, the inside, are hypersensitive. And then thinking back about the gut-brain axis, then of course those signals have to get sort of passed on to the brain. And the brain has a filtering function. Remember in the beginning when I mentioned it's the whole job of the brain to determine, I need to do something about this or I don't. Do I need to go to the doctor? Do I need to go to the ER? And so the brain is responsible for perceiving the signals and then acting on it. And that's where we also know that patients that struggle with these disorders have what we, again, in the medical terminology call central sensitization. So they're more likely, they have a harder time filtering out signals and they're more likely to perceive it louder, right? It's like sort of doing this with the ears, even though you don't want to, right? In the parking lot where you're hearing that really loud alarm. Like what you maybe normally is you would sort of hold your ears, but they're sort of, they can't help but overhear and overhear it. And so this is, and we know this, for example, this is a kind of a funny study that they did way back that in irritable bowel syndrome, which again, just to explain, right, the disorders of gut-brain interaction, depending on the symptoms that patients present with, we sort of label it different diseases and we put it in different drawers. And irritable bowel syndrome is one of them. And it basically means that when you have abdominal pain and diarrhea or constipation for longer than a certain amount of time, then you meet criteria for irritable bowel syndrome. There's no test for it. It's a diagnosis that's made based on symptoms. And if you have that disorder, so to say, if you have those symptoms, you meet criteria for that disorder. There are others such as functional dyspepsia, which basically means after eating, usually after eating, you get more sort of pain in your upper stomach, sometimes associated with fullness, bloating, some nausea. And so there are different sort of drawers: functional constipation, functional diarrhea, functional nausea, and et cetera. It's not so important to go through all of these. It's just the concept, because the underlying problems of visceral hypersensitivity and central sensitization, right, overfeeling and overhearing by the brain are the key problems that are sort of a problem in all of these conditions. And maybe I'll just
No, I think that's a really important, I mean, at the end of the day, right, that's what we're talking about. It's communication. How is our body communicating? So whether you have a reaction to food, whether you have a reaction to a sound, your body is now hypersensitized. The brain has created the pain highway, It's said, this is what we do. We now keep repeating this pattern. The brain's like, we know this. Let's just keep going back and redoing this. And I think it's important for people to understand that once that's turned on, there are ways out of that. And it would be great to talk about at this point, what are the ways out of that? Because we've talked about the brain and the body, the body's overload, whether it's POTS, which we're seeing a lot of in the 20 to 30-year-old population right now, whether it's just reaction to food, and whether you have a diagnosis or not, the brain's involvement in bringing us back is something that we actually have a say in, that we can help ourselves. And it takes time. It's not a switch. We don't flip it. It's a slow dimmer. But I think it's great to talk about, what can we do? How do we talk to ourselves? How do we help our body talk better to itself?
Yeah. So this is exactly, as you're saying, there is no pill for it. There's no, well, first of all, right, there's no single test to diagnosis. And I think that's actually the first part in setting patients up for successful treatment, is understanding that there is, this is a primary pain problem. This is a software glitch. This is, not a diagnosis that needs to be a disease that needs to be found, right? And patients worry about everything, autoimmune conditions and cancer. I mean, the worst things, right, is that what we worry about. It's very hard for families and patients to understand that something that can cause such disabling symptoms there's no underlying disease that we can treat. Sometimes patients even wish for that to happen, right? Because it would be so much easier. I'm not saying cancer, but I'm saying an easier diagnosis that would be easier to treat.
That's a really important fact. And I'm sorry to interrupt you, but that's a really important fact, because there is a point where parents are looking for an actual disease to be labeled, to explain, so that they can attach that. Their brain has a place to go. And with all these new functional neurological terms and disorder terms, that is the new way to give our brains a sense of, we know, as doctors and people in this field helping others, there is something going on. So you don't need a more dire or more proper diagnosis. This is a proper diagnosis. And
this is a proper diagnosis, but it is a diagnosis that is made based on symptoms. And of course, it's the doctor's expertise and judgment of how much testing needs to be done. And some testing needs to be done, right? Especially if patients have a sort of what we call red flags, is certain symptoms that are concerning, like blood in the stool, like a family history of certain diseases, like, certain, abnormal weight loss, like those kinds of things. And I won't go through the whole list, but some testing is needed within reason, but but it's not necessary to make the diagnosis, right? This is very important. These are not diagnoses of exclusion. These are positive symptom criteria based diagnoses, and they're real. And I think that's the other really important thing that I can't emphasize enough, that these are real conditions. They're not in anyone's head. They're not all psychological. They're not, all related to anxiety, those kinds of things that we hear. And this really is the key part of starting treatment, is understanding this, which is why I'm kind of going back to the actually making the diagnosis. So back to the fact that there is not one, because it doesn't follow the medical model. A disease causes symptoms, you treat the disease and the symptom goes away. You have appendicitis, you take out the appendix, the pain goes away, right? These are the sensors that have the glitch. And so what it takes is, in the widest sense, to rehabilitate the nervous system, right? And that's where, Dan, you were also talking about that there are other comorbidities that patients have that's important, right? To understand that when you have glitch in one software, so to say, like Microsoft Word, for example, you have other programs on your computer that can also freeze, right? And that's sort of the idea, that you can have everything that I just talked about in the GI tract, you can have in other parts of your body as well. And so it can be a dysregulation of your blood pressure or heart rate, right? Also regulated by the autonomic nervous system that we talked about earlier. And so it's actually pretty common, and we've studied this, and there's studies out there that when you have a disorder of gut-brain interaction, you are, unfortunately, but by nature, more likely to, or more at risk, or also more likely to have sort of a software glitch elsewhere, POTS, right? chronic headaches, pain elsewhere in your body, dizziness, which sort of goes along with POTS, but those kinds of things. And one thing that always comes up is like Ehlers-Danlos syndrome, right? Being hypermobile. It doesn't require a genetic diagnosis, or the fact is that if you have Ehlers-Danlos or if you're hypermobile, you are, at higher risk or potentially more likely to also experience some of these software glitch disorders, like disorders of gut-brain interaction. And so what it takes, right, to rehabilitate the nervous system, it sometimes takes a little and sometimes takes a lot, depending on how long this pain has persisted and how sort of ingrained it has become and sort of how patients have started reacting to it. But it's a path, and to rehabilitate the nervous system. And we can go into more details in a minute. It's like a balloon with many holes that you have to get at, right? Just like I explained earlier, in this gut-brain axis, when you have disruptions potentially on the level of the gut, right, it very quickly becomes a problem of how you perceive things and how you react. And so that also needs to be addressed. And then it may very quickly, affect how you eat and what you eat and how your parents react to you and or friends react to you. And so before you know it, it becomes a much bigger issue other than just the pain. And vice versa, when you think about pain, the symptom of pain, right? This is a primary pain disorder. Pain is very subjective. We all know that, right? People have different thresholds for pain. And there are lots of different things that affect how you experience pain. And that may be, right, when you're anxious, you're more likely to receive, when you don't sleep, if you are stressed, if you, if there's other stressors going on, if you're sick, you might, all these things, how parents actually react to their own pain or to the patient's pain actually affect how intensely they experience pain. And so before you know it, right, we're following what we call the biopsychosocial model. You have a biological issue, but then there's also your environment, your psychology, all involved in sort of addressing that.
Well, the body becomes so hypervigilant, right? That the eyes are looking for it, the senses are looking for it. Everything's looking for where the next enticer is going to come from. So it's almost so aware that it takes so little. And I think that what's really important to emphasize with everybody here is that this is a training to come back online, to bring this cascading effect that the body's had of slowing down different parts of the body. What, we call it software glitch, but it's a slowing down of different things so that the body can handle what it can handle, because it isn't able to work as optimally as designed. And so when we go to the doctors and we're looking for the quick fix, I think the most important takeaway today is to remind everybody, understanding how the body's way back, how we got in this position to begin with, is the same way how you're going to come back out of this. And it's going to take time and some good bumpers on the lane, knowing that, okay, when my child sees X stimuli, that stimuli might trigger them. Okay, what can I do to buffer that? They're still going to have that response for a certain amount of time until it's a diminishing response, correct?
Exactly. Yeah, and that's actually also in terms of sort of anticipating, the treatment path and the path to recovery, is that it's not a straight line, right? It's more of like we aim for improvement, but it might go like this, right? And so we know that, for example, stressors, infections, things like that can really set patients back. And I think it's important to know that, because when you're aware, you don't get completely demoralized and disappointed if there is some worsening, right? It's not like, not everything crashes. Like, symptoms may worsen, but they're not. You're going to get back on there, right? And I think to talk a little bit more specifically about treatment and this sort of balloon with many holes that we have to get at, is we sort of we try to get at it from all sides, right? We unfortunately don't know, we can't quite prescribe oh, this is going to help this person, this is going to help her. It's usually sort of, we try to get at everything and then pull back. And we use different modalities for that, right? We use medications to help decrease that sensitivity, right? We use we use psychological strategies to help modulate the pain signal, and I'll go into a little bit more detail about that maybe in a little bit. We use physical reconditioning with the help of physical therapy or walks or a sort of appropriate exercise, and we use other alternative or complementary medical treatments as well that I'll go into a little bit more detail later, but to kind of get at it from all sides. And our experience really has been working in a multidisciplinary clinic where, of course, we see some of the most disabled patients by these symptoms, that it really is like a chair with 4 legs. Like if you don't address all of these pillars, it's just not going to be stable, or the recovery won't be stable, right? So you kind of have to get at it. That doesn't mean everybody who has irritable bowel syndrome needs to be seen in a multidisciplinary clinic. I want to make that clear. Those are patients that may have dealt with this for a long time, or where the symptoms have really resulted in a lot of disability. But the idea is that we have to look at the whole patient to treat these conditions, and not just the symptoms themselves, though the symptoms are the disease, and that we want to treat the symptoms because the symptoms are the disease, but there's more to it. That makes sense.
Exactly. And it's really a multidisciplinary approach. No matter what you're looking at how do we calm the body? How do we reinstill in the brain that it's safe again, so that we can get back to this good flow between sympathetic and parasympathetic, so that we're not stuck in fight or flight. And so a lot of people right now are saying, what is the treatment? And so I think to go into more of what is the multidisciplinary approach, is it craniosacral, acupuncture, if you can kind of be a little more specific about a multi-prong approach from that perspective.
So maybe I'll start with sort of medications that we use, without going into detailed medications, but just focusing on sort of the idea of what we aim to achieve. So there are, a number of different medications that help, for example, relax the stomach to hold more food. There are medications like, peppermint oil-based supplements that help reduce cramping. There are antispasmodics, so medications that help reduce cramping, right? So really focusing on the symptoms. If patients are vomiting, we use anti-nausea medicines, and so really focusing on treating the symptoms. We don't use pain medications because we just know they don't help, and they cause more harm than help, because we're not treating a disease, right? We have sort of pain as a primary symptom, but we do use medications that reduce the sensitivity of the sensors, that kind of dull out the sensors, if you will, right? And so those, some of those are borrowed from antidepressants, anti-anxiety medicines. Some are what we call neuromodulators, just to sort of name a few. When we treat patients, we think about, so we know it's a primary pain disorder, but we think about what are triggers. So just to sort of explain what I mean by that, if somebody eats, dairy, something with dairy, and so they have irritable bowel syndrome and they eat something with dairy and they get, significant pain. They might eat bread and also have that significant pain and diarrhea. And so but it may not be only related to these foods, right? So we know they have hypersensitivity. We know that their brain is sensitized, and we would think of those foods as not causing the symptoms, but triggering the symptoms, right? And so patients can have different triggers. Food can be one, not always. It can be specific foods. It can be any food. Stress can be, anxiety can be a trigger. Different things can be, in females, like menses, a period can trigger symptoms. Like there are lots of different triggers, and those are individual to patients. And that's where we also help to really try to understand them and where they come from to really understand what might trigger them. And it's very important to try to address those triggers. And just very important, right? Not causes of the disease, but triggers of the disease. And so that's where a lot of focus on treatment is very specifically tailored to patients. Like if they get very bloated and certain foods bother them, we might treat them for dysbiosis, meaning, certain bacteria in the microbiome are off. So we may prescribe a course of antibiotics. we might recommend dietary restrictions and trying to avoid, certain foods, whether that's just lactose or generally poorly digestible, carbohydrates. Like that's a whole sort of talk of its own. But and so triggers, right? Eliminating triggers is an important part of treatment. And then, the most underprescribed, I think, interventions is looking at sleep, exercise, things that regulate the nervous system and generally just make us feel better and counter that pain, response. And then, we have a big pillar of so that's sort of like focusing on the symptoms and focusing on the gut, right? But then there's this other part that addresses the brain and how we think about things. And that's where, Jenna, you were kind of also alluding to, that this is where psychologists come into place, right? It's not about talk therapy and anxiety management. Yes, of course, all that is important, right? But what we, in the immediate part, what we also look for, very importantly, is very much focused on the DGBI related symptoms. And we know now that cognitive behavioral therapy and GI directed hypnotherapy have very good evidence to show that these are not only essential in the treatment of patients with disorders of gut brain interaction, but also need to be part of the treatment. And the main focuses are so one is restructuring that thinking, how we think about symptoms, right? Back to that example of, going to school, maybe being worried about being in the bathroom stall for too long, right? Like either learning to be more flexible about that thinking or doing almost like exposure therapy where with the help of the therapist, you are in these kinds of situations to help reduce the worry about it. But also to teach patients methods to calm their nervous system, right? Whether that's through, muscle relaxation, breathing techniques, meditation techniques, kind of what works for patients, right? But a very important part to counter that state of arousal that's associated with chronic pain. And then the gut-directed hypnotherapy is sort of where we try to alter that signal that is happening in the body. So, right, hypnosis, as many of you may know, is sort of the idea is with imagery or words to get patients into the state of focus, and in that state of focus to suggest a change to their symptoms. So maybe warmth in the hand that's brought to the belly, and is then transferred onto the belly and will stay after the therapy session is completed, and sort of repeating that to actually suggest a change in how the body feels certain things. And the great thing is that it's actually been shown that it's just as effective if you do it with recordings than with a therapist. So that's really something that can be practiced and taken home. And then we move into the world of complementary medicine, which can be very helpful. Unfortunately, we don't have that many studies that sort of back up a lot of these interventions, but craniosacral, acupuncture, those are for some patients, you have to give it some time to really see if it makes a difference. But for a lot of patients, it works very well. Yeah, a new kid on the block for these disorders of gut-brain interaction that some of you may have heard something about is the so-called IB-Stim device. I don't know, Dana, if you've heard of this, but it's a device that looks almost like a hearing aid, but it's basically acupuncture of the ear, of certain areas of the ear that are actually related to the vagus nerve that we talked about in the beginning, which is part of the autonomic nervous system, and it helps regulate its function. And it's now, we've started using it quite a bit, and some patients are really experiencing significant relief. And so, one more sort of piece in the puzzle that we can utilize.
And I have heard about that recently. There's a lot of talk here in Los Angeles about using that, and I have heard good things. And I think it's important to talk about how the brain is getting stuck in these sticky neural loops, and how Dr. Zeltzer and what she's done with CHIP, Creative Healing for Youth and Pain, is really about understanding how the brain's role in any of this, how the software gets the glitch, whether it's, POTS, Ehlers-Danlos, whether it's the stomach ache, it's a headache, it really doesn't matter. You can fill in the blank. The brain's involvement is really the same. It gets stuck in this sticky neural loop. And then the patient, whether it's an adult or a child or anybody, just starts to limit the parts of the brain that it wants to get to because it's starting to narrow in the safety. I would call it a safety loop, right? It's just getting into this one lane, the lane they know is going to cause the least amount of reactivity in their body. Fill in the blank with the reaction in the software glitch. And so what Dr. Zeltzer's realized is the way back is, how do we get out of this one little lane? How do we change lanes? And it's doing something different. It's doing something creative, which I can hear every parent right now on this saying, I can barely get my child out of bed. I can't get my child to school. How am I going to get them to do this? But what's amazing is we've seen time and time again that when they do anything other than what they were doing in this very narrow lane, we're starting to see the brain come back. Again, it's slow, and it's so important to reiterate, the process is slow. It's a training program for a marathon, especially if this has been in the body longer and longer, that we just keep doing a little bit more. If we get our child to get out of bed and go left instead of right, I mean, I jokingly say that, but it's as simple as these minor things, right? To get the brain to acknowledge we were safe when we did something else.
Yeah. Absolutely. And I think it's, in a way, it's counterintuitive, right? Because whenever the first response pain, abdominal pain, not feeling well, is lay in bed, rest, recover, right? And this is exactly not what we want to do, right? In this situation, it's almost like thinking about, a broken leg that's in a cast. Like, we have to start moving it at some point, sooner than later, actually. Otherwise, your muscles are going to atrophy, and it's going to be even worse, right? Or you might have even worse pain if things get stiff, right? So this concept of these disorders of gut-brain interaction are real, and this pain it's a hurtful but not harmful pain, right? So and the approach to hurtful pain is very different to harmful pain, right? Harmful pain would be like, if you don't do anything about it, you would get very sick, like appendicitis that's not treated, right? And this hurtful pain, really part of the rehabilitation is to rehabilitate, right? Almost like doing physical therapy for the GI tract, and part of that is moving, getting out, and actually functioning. And we see this all the time, and it's been shown that actually functioning often comes before improvement of the symptoms. And at least it goes hand in hand, right? And going back to that analogy, right? You're at the parking lot, and you're hearing this really loud car alarm. You can't focus on anything else, right? Your whole mind is just absorbed with this super loud car alarm. And slowly but surely, part of this, like what you were saying, Adina, about learning to refocus and getting rid of that super highway that's become established from this chronic pain is shifting the attention away and retraining your brain not to focus so much on that. That's basically just other words of what you were saying.
And sometimes it's just getting to a new provider, right? Somebody that sees them and hears them and says, I understand your body's doing this, right? So then they put in whatever, acupuncture, somebody asked about cupping. I think, my understanding is just getting to something that gives you hope and gives your body a sense of this could work. Now, the downside to that is I feel like many teens are looking for the instant I went there and it didn't work. Right. But we know if we can get you to go back a few more times, we get you over that hump, you might actually see some improvement that allowed you to do something else unrelated that then gave you a little more expansion in your lane.
Yeah. Yeah. And I think it's challenging the patients, right? The patients have to have that can sometimes, be challenging. But, also for parents, it's very, very challenging when you have a child that's not getting out of bed or refusing to go to school or doesn't want to participate in certain activities or even missing out on, little events here and there because of symptoms. It's really challenging, right? You see that they're not feeling well. I mean, they clearly look unwell because, again, they're having real pain, right? So they might look pale, nauseous. Nausea is an awful feeling, right? So these are very real symptoms. And I think supporting children or teenagers or patients with that, one really helpful way to think about it in terms of thinking about rehabilitating is acknowledging the pain, first of all, just like we as doctors do, that the pain, the symptoms are real, and thinking of it not as, but you can still do all these things, but and you can still all do these things, or maybe just one little thing, right? Slowly but surely. It's not mutually exclusive, and it's about learning to integrate so that things can get better over time.
Yeah, and piecing it down. If your child can't get out of bed or just said, I'm in too much pain, I'm not going to get out of bed. Sometimes it's like, well, can you get up and brush your teeth? Right?
Yeah.
Get up to these little pieces of chunking down to something little, because then they realize they didn't get worse. That's the whole premise behind going to a pediatric pain rehab, right? 21 days to reset. That's not necessarily healing the disease, but it's telling their body, after 21 days, I didn't get worse. I'm still here.
Yeah.
And then their body has the ability to now do the next piece if they so choose to do it.
Yeah. Yeah.
But I think that it's really important for parents to know that the kids are going to put up a fight. I'm sure I'm reading the chat right now and everybody's saying, what if my child doesn't want to do this? What if my child doesn't do that? And I think what you just said is probably one of the most important things, which is hearing them and letting them know that what they're experiencing is real, whether they look healthy, whether they look like they should be getting up and running, that they really are experiencing some dysregulation in their system, and being heard and felt is probably one of the greatest gifts we can do as parents and as educators, and certainly as physicians. And having somebody like you who really gets this, I mean, all the patients that are fortunate enough to get to see you, I'm sure, get to some form of health a lot faster because their doctor saw them.
Yeah, well, that's our hope and goal, of course. And you're right. I think I do want to say that, there is a spectrum of the severity of these disorders, right? And so there are some patients that are very mild, like we know, 10% of school-age children would meet a criteria of a disorder of gut-brain interaction, but maybe never actually came to medical attention. And then we have, we judge the severity of these disorders by the degree of disability in a way. And so that also determines how much support patients need, right? Sometimes it's a primary care who sort of has a feel or knowledge of these conditions, and that's sufficient. They don't need a specialist. And then sometimes they come to see a GI doctor or a specialized multidisciplinary clinic like we are lucky enough to have at Boston Children's, that consists of a GI doctor, a psychologist, a dietitian, a pain physician, a nurse, and sort of a whole team to support and work with the school and explain to the school and work on school reintegration and those kinds of things. And then sort of, if patients need even more support, right, like what you were saying, Dana, is an actual program, a pain rehabilitation program, right, where it's sort of, you get an intensive rehabilitation that may not resolve things, but it helps patients learn coping mechanisms, learn key tools to reduce the pain signal, get some treatment with medications if needed, and just help them get back to life.
Well, and one of the best things that we can do is do these webinars, because we're putting out content so people understand concepts that not all doctors are talking about, right? They're so focused in, okay, you've seen me for stomachache, I've got nothing to diagnose, and I'm moving on to the next patient. And although that's how it works, these patients really need somebody to say, and we understand this. And so in addition to physicians doing their piece, we have physicians that join our webinars, and we're so grateful for that, because I know they're part of our team. They're our expanding network across the world, because we're a global webinar that can get this information out. And that's why this is so important when doctors like you join us, because you wouldn't have known about a pediatric pain program. And by the way, you might not be able to actually get into one. So what do you do in the meantime? What do you do when you're waiting to get into a pain doctor? What do you do when you're waiting to get into any doctor these days? Having parents be really empowered. And, Dr. Zeltzer just reminded me, which is, don't ask about their pain, right?
Yeah.
Don't, try not to go straight to the pain. We kind of have to work around it and yet see it. So that's a really interesting dance that parents have to do.
It is, and it can be very challenging, but that is, the way that we as parents, our parents react to the pain it plays a huge role. And exactly, not asking about the pain. In fact, this has been studied, patients with a DGBI, parents, one group was instructed to actually, ask about the pain. The other was to acknowledge, but not, actively ask about it, and not perseverate on it. And patients, the latter group, had much lower pain scores, just because we're not constantly reinforcing that highway that's already getting established from this like rock concert right in the intestines and in your insides that is a result of the software glitch, right, that you're hearing this pain signal so loud. We don't want to feed into that. We want to help reduce it, not ignoring, right? There's a big difference between acknowledging but not focusing on it and ignoring, right? That's not the same thing. And
what would be a good example of that? What's a great example of that? I think parents could really benefit from hearing from you. What should they say to their child? They want to say, what they really want to say is, how do you feel? Are you in pain?
Yeah.
What should they be saying?
Yeah. I mean, it depends. Like if the patient really is looking very uncomfortable, right? You can say, you look unwell, or I know you're not feeling well, and let's go sit at the table and just have a bite to eat there together. Again, not focusing on that, and certainly not like, don't even ask about the pain. Like, what's your pain like today? Or, how are you feeling? Or if focusing so much on that, focus on the activity or on, what to do rather than on the pain and the symptoms.
So it's really just giving them a place. I like to refer to it as a bumper on the lane, right? If your kid's having a dysregulated day and they're screaming, as a parent, we should get more quiet, not more loud, right? So if their body is really loud, we as parents need to be quiet and just sit with them. And I like you saying, let's just go sit down, let's go watch a show, let's go do something, let's walk over here. I mean, there's just little baby steps, and I can't reiterate enough that the road back is a process. And so for everybody not to be looking for the next, the next pill, the next switch, it's a, you keep saying multidisciplinary approach, even as a parent, of what we say, how we do it together. But we're all in it together. And with thanks to you for being able to be with us today, and to Dr. Zeltzer for her incredible work on this, because we've seen kids come back, and we stand on these webinars as pillars of hope, to show that people get better. They stop having POTS attacks. And maybe you could talk about POTS. I know we've alluded to it several times, but I don't think we've actually explained it. So those that don't know, we maybe should spend a moment telling that, because that is a key component when you get severely dysregulated.
Yeah. So POTS stands for postural orthostatic tachycardia syndrome, and basically, the definition is that patients, when they go from supine, laying down, to standing up, their heart rate increases more than you would normally expect to increase, and they often experience symptoms such as dizziness, palpitations, nausea, and that can be very, very disabling, including having syncopal events, right, when they pass out, for example. And again, we often see this, closely. We often see this in patients that also have DGBI, and often, again, chicken or egg, right? I'm so nauseous because of POTS. The nausea is a GI symptom, right? We need to treat the POTS to get the nausea under control. We also want to treat the nausea. So that's a perfect example of how we need to treat the other software glitches in addition to the GI software glitch to help the patient, the most that we can. And actually a very other important pillar of treatment is treating the comorbidities. So treatments for POTS, again, the idea is similar to treating DGBI, but in addition to taking sufficient fluids to make sure that intravascular volume, like the blood, the amount of fluid in the blood vessels is sufficient, and actually increasing salt intake, or being very generous with salt intake. Certain physical therapy exercises can be very helpful, and with those interventions, for most patients, symptoms actually improve significantly. Sometimes the nausea can prevent them from taking enough fluids. Again, that's where sort of the GI doctor comes into play. But and it's rare that we actually need to go to other medications to help support, reduce the heart rate or support blood pressure.
And are you seeing that with vagus nerve stimulation, there is some help with regards to this?
Yeah, so no studies to show that the symptoms of POTS, but we definitely know that autonomic function is altered. So that's just a matter of time, I think, that we learn more about that. It started with just learning that the IB stim helps IBS symptoms, but we are now also seeing that it helps, which is mostly pain, diarrhea, constipation. We're also seeing it now help with nausea. So clearly other symptoms that are a result of this dysregulation are being helped by it.
Yeah, it makes sense if it's one of the communication highways in our autonomic nervous system, that by doing a proper stimulation, that it could help. Well, I know that we are down to our last few minutes. Is there anything, the most important takeaway that you'd like to give parents for self-empowerment in this process? You've given us so much information, so I know it's a little bit loaded, but.
Yeah. I'm sorry, I just saw a question pop up. Yes, we were just talking about IB stim. I just happened to see that. Yeah, so, again, I can't emphasize enough the fact that symptoms or pain and other symptoms related to disorders of gut-brain interaction are real. They're not in patients' heads. They're not made up. They're not all related to anxiety. And that they represent a soft glitch and require a rehabilitative approach to really treat them. And I think acknowledging that they're real is really probably the single most important part in getting patients well, because you sort of start with accepting it for what it is, right? And I think the next, the last thing that I want to say is, do have patience. It's a path, and we, as in physicians that manage patients with these disorders, sort of are there to hold your hand. Don't expect, as much as we would like to have that immediate fix, don't expect that immediate fix. Give it time for the rehabilitation, and remember that functioning is very important despite the pain, as counterintuitive as that may be.
Well, this was an amazing and informative time with you, and I know that people got a lot out of it. I can see by some of the comments, and I want to remind everybody that this is a taped webinar. You can find it on YouTube if you go under Creative Healing for Youth in Pain. Also, you can go to mychip.org. You can find all of our past ones. I think they all really interrelate. I think so many times, we look at what the treatments are, and so often it's how can we help ourselves get back, and it's through information. So I'm beyond grateful for your time, your expertise, all your knowledge, and for everybody who joined us today. Thank you, Dr. Zeltzer, for forming Creative Healing for Youth in Pain, which allows us to do this, and for everybody joining us today. So it is 10:59. In the interest of time, I will thank everybody and say we'll see you in the new year when we do this again. And I hope, Dr. Beinvogl, if you want to, we can do this again and continue this dialogue, because it was really informative.
Wonderful. Yes, happy to come back anytime. Thank you for having me.
Thank you. Thank you, everybody.